Today's webinar is titled Quality Management for EMS Beyond Chart Review, presented by Rob Walker, Education Specialist at Emergency Health Services Federation. I'm going to pass it over now to Rob. Rob, thank you so much for being here today to share your knowledge and experience with us, and we look forward to the presentation.
Thanks, Rio. I am glad to be here, and I'm glad to see that we've got a good group of people in the room today, because when you start to talk about quality improvement, people's eyes glaze over, and it's, one of those topics where it's kind of like a necessary evil. But I promise you'll have some fun with this presentation today, and hopefully you'll be able to walk out of here with some things that you can take back to your department. So I'm going to show you my slide deck, because you don't need to look at my messy office and my almost bald head, but some of the slides that I have will help to illustrate some of the points that we go through when we're discussing topics here with quality improvement. Before we get into anything else, I just want to tell you I have no financial conflicts of interest relevant to this activity. Nobody's paying me to be here today. I'm here on my own free will. And we do have a few learning objectives. Of course, I want to make sure that we walk out of here with some positive knowledge at the end. And we're going to talk briefly about some quality management strategy. And you'll notice I call it quality management. And I'll talk about that. I'll show you how to develop a factual problem statement and then put together a PDSA cycle, which is a plan, do, study, act cycle. And then you'll be able to take this stuff back and use it at your own agency. And I'm looking at the Q&A here as well as we go through. When I see questions pop up or in the chat, yes, I will be able to share some of these slides with you. And this entire presentation will be put on the YouTube channel from NAEMSE. So you'll be able to go back and watch it at your leisure. All right. We've all had this reaction when somebody says, the QI guy wants to see you in their office, right? This is one of those things where, especially if you're a paramedic, if you're a new paramedic, you're like, oh no, what did I do wrong? And this is a mindset that I want to get out of. I want to get rid of this idea that quality is punitive. And if we can take that entire mindset to heart, we're going to find the process to be a lot easier. Quality should never be punitive. It should be all about system improvement. And there are a couple of things that go along with this that are important to know. Quality improvement and quality assurance are not the same. A lot of places use those terms interchangeably, and they are just not the same. If you're doing quality assurance at your agency, you're checking compliance against standards. Did this guy start an IV? Did they give aspirin to the chest pain? Quality improvement is a separate process where you're looking holistically at your entire system. If I notice that there's a large group of providers who aren't providing aspirin, that becomes a quality improvement issue. And we want to see how we can take the data that we collect in our PCRs and, through our daily operations to fix issues that we see developing in our system. And that's really what this entire lecture and this webinar is all about: how to mine your data to get the information you need to get you to a better place. So we're going to probe system performance today and create change initiatives that actually work. We find that most of the time when we want to make change, it starts great. We start house afire, and then we generally lose interest because it's a lot of work. It takes a lot of time to make change, and it's painful at times. So when we're working on change initiatives, we have to stay the course. And the data that we mine from our PCRs and from our web data, or our WebCAD data, if we're using computer-aided dispatch, we can get a lot of information from that and make some positive changes. But before we move forward, we kind of have to see where we were. And the idea of using quality improvement is not new, and it's been around for a while. Think about hand washing for a second. We all know that if you wash your hands, you can prevent disease transmission. That was not always the case. This guy, Ignaz Semmelweis, was an OB/GYN doc, and he noticed that babies were dying and mothers were dying. And he realized that if he washed his hands, fewer babies and fewer mothers died. It was a little causation equals correlation. Now, his contemporaries thought he was out of his mind. In fact, they gave him such a hard time that he had a nervous breakdown. He was then committed and later took his own life, all over the idea that he knew he could make some change. He made some positive change and nobody believed that it worked. So yeah, when we're making change, it's important that we have disciples that help us to spread the word. Unfortunately for Dr. Semmelweis, it was a little too late. But when we think about the idea of process improvement, it seems really simple. It was simple for him. He identified a problem, he made a change to fix the problem, and then he moved on to the next thing. Unfortunately, it's not quite that simple. It takes a lot of work to identify and fix problems. It's never just an easy fix. And then you can never really move on to the next thing because you constantly have to go back and measure your successes and make sure that you're staying on the right track. There's books and books and books about quality improvement. Lots of strategy, lots of theory, lots of ways to put this in practice. And we could go for hours and hours. Matter of fact, there's a class at the National Fire Academy that's a 6-day course all about implementing quality improvement in your agency, whether it's fire department or EMS agency. We're not going to spend 6 days on this. We're going to spend an hour today, and I'm going to show you one very simple system. When we think about quality improvement, we can't talk about quality improvement without talking about Deming. He's the guy that really took quality improvement and put it into place in industry. And then from there, it moved back into healthcare. Quality management is what Deming calls this, TQM, total quality management. And he's really got 4 points in his plan when he develops a quality management program. And those 4 points are simple, but difficult when you think about implementing them into the framework of healthcare. Consistency in the process, removing barriers, delivering education, and then making the process the focus. That's really good if you're making cars or building widgets. It's really hard to do when you're treating patients who have variable presentation and, a constellation of symptoms that don't seem to match. How do you figure out how to make total quality management work in that framework? It's difficult, and we try to bring some of these total quality management ideas into play. And when we do that, we've got kind of a cycle that we follow. And you notice that this cycle is continuous, and it starts with continuous improvement. And as we work through a continuous improvement cycle, that's the message that we need to convey to our team members, that this is not a one and done. This is a process that never ends, the wheel in constant motion, where we're making decisions based on evidence. We develop a process. We've got leadership and team engagement to drive that process. It's all about the patient. We're getting there to drive outcomes for our patients. And as we look at those outcomes, we make changes as we need to. We look at the evidence. We develop a new process. This is the cycle that goes round and round and round. And a quick, easy way to do this is with PDSA. So here's what we're going to talk about today. And this is really kind of the crux of the whole thing. Why does it matter? What are we going to measure? And then once we measure it, what do we do about it? And this is where I see people get into trouble all the time, because if you look at your agency's data, there's lots of things that you can measure. There's a zillion data points that you can measure. And if you let yourself get bogged down in that, you will never be able to achieve any of your quality initiatives, because you're just going to be buried in numbers and charts and graphs and however you make it pretty. So what we're going to talk about today is how to narrow the focus and how to develop a quality improvement initiative that actually works and can get you some results. So we know it matters. We know that quality improvement improves safety for everybody involved in the operation. We know that quality improves patient outcome. It can improve system efficiency. It can get your crews back on the road faster. It can get your crews to the hospital faster. And if you're following a really strong quality improvement initiative, you can reduce cost and equipment waste, which makes everybody happy at the end of the day because we want to save money. So it really does make a difference operationally, and it really does make a difference in patient outcomes. Getting your team to buy into this is sometimes difficult, and I like to show solid results. And as we work through some of the projects that I'm going to discuss in this webinar, you'll be able to see how you can hand your team some really good, solid metrics that they can hold in their hand and see that the changes they're making are improving. So when we think about the measurements, like who decides what we're going to measure? And there's a whole set of benchmarks that we can look at. The National EMS Quality Alliance used to be called EMS Compass, and they're a group of EMS leaders and quality management professionals who work together cooperatively to develop benchmarks nationally. And we use a lot of the NAEMSE data for this. Regionally, agencies are using data to benchmark their performance. But what we're doing is improving patient outcomes through the use of quality measures collaboratively. So being able to look at lots of data to see how you compare against your region or against services that are similar in size and call volume, or in your geographical part of the country or even nationally is important, because if you don't have a map, you have no idea where to go. You just know that you want to go west. You don't know how to get there. And the quality measures that we benchmark against are those kind of guideposts that help us to get to where we're going. There's lots of other people that use your data as well. And we'll talk about making sure that you have clean data, but lots of people use it. And obviously, if you're involved in purchasing or being involved with the implementation of an EPCR product, you are very familiar with NAEMSE and the criteria that they use for data collection. There are lots of other folks on the periphery who use your data to help guide their systems and help grow their practice, and the National Trauma Data Bank and the CARES Registry. If you apply for mission lifeline recognition, that's used. Get with the guidelines with stroke facilities, they're looking at pre-hospital data as well. So lots of people are using your quality metrics and they're benchmarking your performance against others. So it behooves you to do a good job with your data. Now the question is what to measure. And as I mentioned, there's lots of things that are out there to measure. And some of the more common ones you're probably already familiar with, but I don't know if you're looking at them. And this is, where we get to that place where let's decide what we want to measure. Blood glucose for CVAs is, a big one. Cardiac chest pain, your on-scene time to the 12 lead time. Lights and sirens transport is a big one. We're seeing agencies now that are starting to reduce their lights and sirens transports by 80%. CPAP administration for CHF, how quickly do you get CPAP on board? Aspirin administration for STEMI or ACS. These are, low-hanging fruit because these data points are pretty easy to mine. But what you should remember is you need to measure and act on the data that's important to you. And some of these may be important to you. Some of these you may not care about. You may say, I'm a BLS agency. I don't care about 12 leads. I'm in New Jersey. Our guys aren't doing blood glucose. So whatever, find the things that matter to you and start to measure those. And the idea of this is the data is huge. And we have lots and lots of data to dig through. And, it all goes back to that old adage, right? How do you eat an elephant? One spoonful at a time. And that's the way we need to look through our data when we're managing quality improvement initiatives, a little bit at a time. Because if you start to scoop this thing up with a ladle, you are going to drown in data and you will become discouraged and it will go back to the bottom of your to-do pile. So, a little bit at a time will help you get there. Some of those common patient care measures, again, these are the big ones that people are looking at currently. Blood glucose, stroke assessments for stroke and TIA. And when I say that, I'm completing a full stroke assessment. Cardiac arrest, we look at compression quality and airway management, outcomes with a supraglottic airway versus intubation, or for chest pain, aspirin administration or 12 leads. There's a myriad of data points that we can look at. Operational measures, right? Maybe the shoot time, how long it takes from dispatch till the wheels are rolling, how long it takes to get to a scene. A good average is, most agencies are using 2 minutes a mile. If you're 2 miles away, it should take you 4 minutes response time from wheels rolling. The amount of time you spend on scene. And then one of the hot buttons currently is turnaround time from arrival at the hospital to available status. And this is a big one that a lot of agencies are talking about measuring right now and are seeing huge amounts of frustration. You can also look at individual measures. And this is a really good way to benchmark your individual performance over the course of the year as you're starting to look at what you're going to test for core competencies or build continuing education modules, right? We want to look at IV success rate and endotracheal intubation first pass success rate. A couple of really interesting ones that can help you find problems that you might not be aware of. Controlled substance administration by individual medic. ALS to BLS downgrades, are they appropriate? Do they meet your criteria? Are you going to identify trends where you're seeing more downgrades at shift change? So obviously things that you want to look at in your system performance. I mentioned data accuracy, and there are 3 big points when it comes to making sure your data is accurate when you're building quality improvement initiatives. Accurate data is stuff that is input to the system correctly. This is, last names spelled correctly. This is date of birth, social security number for patient tracking, correct run numbers, correct units of measure for medication administration. This is accurate stuff. This is, pay attention when you're typing. Data that's authentic is data that can be verified. These are verified times that we use from a cardiac monitor or a computer-aided dispatch import. This is stuff that we know is a real legitimate time hack, and we use that to balance against our perceived time. And then genuine data is real, truthful information. This is stuff that you have to count on your providers to have integrity and be honest when they're entering information. Without accurate, authentic, and genuine data, what you get out is only as good as what what's being put in. So you have to take some of that with a grain of salt. And a perfect example of inauthentic data is at patient time. This is one of my biggest pet peeves because we see this all the time, right? You arrive on scene at 12:15. When are you at the patient? Well, most providers go, well, took me about a minute to get my stuff and walk in, so I was at the patient at 12:16. Were you really? Was that really the time you were at the patient, or did it take 4 minutes to get there or 6 minutes? You can solve this by simply starting a process of, hey, when you get to the patient, mark at patient with the dispatch center and they can put it in the CAD. Or turn your cardiac monitor on, and that will provide a time hack that shows you were at patient, and then you can enter that into your PCR data. However you want to do it, but you've got to make sure that the data you're using is authentic, accurate, and genuine. Okay, so now we've looked at a bunch of things to measure, right? We've got some ideas, and maybe you're thinking to yourself, you know, when I get back, I'm going to dig into EMS charts or image trend or ESO or whatever you're using, and I'm going to start to look at some of the analytics and see what is some low-hanging fruit. That's totally cool. And again, measure what's important to you. But now that we know what we want to measure, how do we do it? How do we put this data to work? How do we start to take these raw numbers and turn them into something that we can use? And this is where we use PDSA. And if anybody has taken a quality improvement course or maybe done some lean training, maybe taken an intro to Six Sigma, some of this will be very familiar to you. And PDSA is my favorite method for building quality improvement initiatives based on data that is collected from PCRs and from, you know, our readily available data sources. So PDSA, this is where we plan, do, study, act. And in a nutshell, we decide what we're going to do, and then we do it. All right. When we do it, we study how it came out. Was it good? Was it not good? And then we decide what we're going to change. That's a PDSA cycle. And if you ever learned how to ride a bike or ski or snowboard or do anything else, you, in your mind, went through a PDSA cycle. You said, okay, here's what I'm going to do. I am planning to ride this bike. And then you do it. And then you fall off the bike. You think to yourself, you know, if I lean a little bit more to the left, I won't fall off the bike. And then you act on that. You say, you know what, I'm going to lean to the left this time. And you run that PDSA cycle again. And that is how PDSA works when we are working through quality improvement initiatives. Let's take a quick break. Do we have any questions, comments, thoughts as we're working through here? I'm looking at the chat. Nicole just sent a note. She said she's having some difficulty. I believe, Nicole, that the recordings will be available within a day or two, and they'll be posted on the NAEMSE YouTube channel. All right. So seeing nothing in the chat and no open questions, we'll move on here a little bit now that we have a good idea as to how a PDSA cycle works. Let's think about this. This is a conversation I had with a friend of mine in the Midwest a couple of years ago. This was pre-COVID. He called me and he's like, hey, I got a problem. Chief said crews are taking too long at the hospital. It's taking them close to an hour to get back to available status after getting there. Fix it. And I said, how's that going for you? He goes, well, not as well as I thought it was going to go, because I thought it was just going to be an easy fix. And what he did was he just said, hey, you guys get back in service. Stop messing around, right? They said, we're going to do a PDSA cycle where we're going to put out a memo and tell all the crews to get back in service quickly. They put that memo out, and 6 weeks later, nothing changed. In fact, it got worse. It took longer for the crews to get back in service. And the reason why is they assumed the causation before they investigated. And when I talked to Jimmy, my friend, about this, he's like, yeah, he goes, you know what? I thought that they were just being lazy and taking a lot of time to get back in service. And that was not the cause at all. Here's where Jimmy and his group went wrong. They never created a problem statement. And the problem statement is a way that you can identify what happened. And Lee just put a note in the chat that I thought was interesting. He said, hospitals are so full, it's usually not EMS's fault. That is absolutely true, especially now as we're seeing lots of hospital overcrowding. And again, right, this was pre-COVID. This was before hospitals were on that I'm always on divert status. But as you'll see, you're partially correct there. So when we talk about problem statements, you have to identify a real evidence-based problem. You have to shrink it down to the point where you can't just say it's taken everybody a long time, we have to fix it. And you can't assign faults or assume a cause or presume a solution before you investigate. You have to come up with a hypothesis, and then you have to investigate to develop a solution. Here's how we get to solutions, folks. This is probably the best thing you'll take away from this, the 5 whys. If we ask why, if you've got toddlers, you're familiar with this. Ask why. Normally 5 whys will get us to the root cause. All right. The ambulance was out of service. Well, why? Well, because it was out of gas. Okay. Why? Because it wasn't filled at the end of the last shift. Well, why? Well, because we don't enforce the return with a full tank policy. Okay. That right there gets us to the root cause. We don't enforce the return with a full tank policy. Well, why? Well, because the supervisors don't want to be the bad guys. Okay. So we have to find a way to change that behavior. 5 whys can get us to the answer in most cases. Sometimes it takes fewer than 5. But 5 whys is a great way to examine the root cause of your problem. So here was the problem statement as it was put together, right? Crews are taking too long at the hospital. It's taking them close to an hour. Fix it. If you looked at a problem statement factually and said, we're failing in our efforts to provide coverage to our primary districts due to extended turnaround time, the failure to coverage can adversely affect patient outcome, decrease satisfaction, reduce public confidence. The root cause is unknown. Therefore, the cost and process of correction is unknown. We have to do some research. And it's important that we state this problem clearly in the beginning so we don't develop any biases to the cause of the problem. So when they started to run through the whys, here's things that they found that they weren't aware of. There were lots of delays in assigning rooms at the ED, which is a problem that we see now, right? That's a big cause of ED delays. Crews had to travel 20 minutes before they would arrive back in their first due because the hospital was outside their first due area. They weren't statusing correctly with the computer-aided dispatch console. They weren't marking themselves back in service when they were back in service. They were marking themselves back in service when they were back in quarters. They thought that they could only get a break if they stretched their at-hospital time because nobody watched it. And there was lots of goofing around on the ramp, which is, it is what it is. So these reasons helped them to develop a quality improvement initiative to improve their turnaround time. So they did some education on correctly using CAD status. They said, listen, rather than waiting till you get back in quarters, you can go back in service on the CAD before you're in quarters, when you're back in the area. They had discussions with the hospital EMS liaison to work on throughput. I think every EMS agency on the planet is having those discussions. They increased the presence of a supervisor on the ramp. And that was not to roust everybody out. I mean, that's kind of what part of that was, but that supervisor there also was an accountability presence. They also understood that sometimes the hospital at hospital wait time was going to be extended, and you just had to accept that as the cost of doing business. And then they worked on changing the culture. Listen, guys, we want to make sure that you feel like you're getting appropriate breaks and that stretching out your hospital wait time isn't the best way to do that. It was cultural change, and that was the hardest one of all. But working on some of those small things made a big difference. And that's really what quality improvement's all about. Small changes, small incremental changes can lead to big differences. Okay, I want to talk about a real case study with an agency that I was involved in. And this is one of my favorite quality improvement studies because it was something that I had no idea was an issue until I started to dig. So back in 2018, the service I was working at replaced our old aging Philips MRX monitors with Zoll X series monitors. And with that came a very nice comprehensive set of data mining tools with Zoll Online. I was able to get a lot of information from Zoll Online. And we discovered that our CPR performance was awful. It was horrific. And we never knew. There was no way we could measure this. And one of my favorite statements was, my boss looked at me and he said, really, Rob, it might have been better if we didn't look. And I said, yeah, but you got to look. You've got to find the answers to these things. So we started to look at our CPR performance, at our performance during cardiac arrests, and we made some dramatic changes. And Tom Boothlet, who was at Hilton Head at that time, was a great resource. And I said, Tom, what are you doing to improve your cardiac arrest performance? And he said, well, we're doing a really nice CPR report card. So we started doing some stuff too. Before we got into this, we made a problem statement, right? We reviewed our cardiac arrest data. We discovered gross deficiencies in rate, depth, and overall quality of compressions and CPR pauses and lots of problems. And we don't know why that's happening, but we're going to start to make some changes here. So we put a problem statement together and then we started looking, right? We did a PDSA cycle. We looked at how we were performing CPR and interventions during cardiac arrests. We looked at the results. We decided to implement some changes and we ran that PDSA cycle again. So following Tom's lead from Hilton Head, we built a really nice set of data collection tools. And these report cards went out to everybody who was involved in a cardiac arrest, usually within 24 hours of the arrest. We mined the data from multiple sources. We looked at the data from Zoll Online. We looked at the PCR data. We looked at the time hacks from the WebCAD, and we were able to build a report card that helped us to show performance deficiencies, and it was non-punitive. This is the important part. Nobody got in trouble for a really crummy cardiac arrest. We pushed this data out for self-reflection and as a conversation starter and to help us identify trends. So if you were on a cardiac arrest, if you were a firefighter, if you were an EMT, if you were the paramedic, you got this data set to look at and discuss. And it really fostered some great discussions when people would come back and they're like, oh, I didn't realize it was that bad. We found that our rate was pretty crummy. And I wasn't really happy with the Zoll internal metronome. So we added metronomes that were set at 110 beats per minute to all of our cardiac monitors. And we trained with these. So these little metronomes were like $6. We bought them on eBay or Wish or somewhere. And if you broke one, big deal. We just bought a bunch of them and we had them on the cardiac monitors. We did a daily 2-minute CPR challenge, and we used QCPR mannequins from Laerdal, and we measured performance from every provider at shift change. And we made it kind of gamified where everybody would compete against each other. We gave away some gift cards and some t-shirts and had some fun with it. And we did CPR every day at shift change for 2 minutes. Also understand that we were not using at that point mechanical CPR devices. There was no Lucas device. So all the CPR was manual CPR. Then we provided some high performance CPR education and reinforcement where we stressed rate, depth, quality of compressions, the team approach to CPR, and we worked on some one-on-one coaching with the medics, and we did some kind of individual remediation pieces when we noticed some trending. Once we started to do this, did we see changes? Well, yes, we did. We saw our CPR performance, rate, and depth increase dramatically simply based on the small changes that we made using the metronome And using the daily CPR challenge provided amazing muscle memory for the providers. And you'll see in January, we stopped doing the daily CPR challenge and the performance started to fall off. This is one of those things where continuous improvement was needed to make sure that we maintained high quality in our CPR and our resuscitation. But I was able to measure dramatic improvements in rate and depth from CPR just by looking at our performance from the Zoll online and the CPR feedback. So, at the end of the day, can you make improvements? Well, yeah, you can absolutely make improvements to your system, but it takes a lot of work and it takes a lot of time and it takes a lot of buy-in. You have to develop system plans to move your system forward using the data that you mine. And the best way to do this is really start small. Find that low-hanging fruit, right? A singular item that you can monitor closely and watch the performance as you're running through a PDSA cycle, as you're making changes. If you decide that aspirin administration for cardiac chest pain is going to be your focus for the next 6 months, then, develop plans to maybe put the aspirin in a place where the paramedic will see it quicker, or put a big yellow sticker on the cardiac monitor that said, think about aspirin, or whatever, however you decide you're going to try and improve your system performance. Start small with one thing. And remember that small successes lead to a cascade of positive change. And you will see that the program of change will dramatically improve. So some of the things that we talked about are easy to change, right? Some of these things are easy to do. Here's the big takeaways. You need to avoid collecting meaningless data. Don't measure things that don't matter. And don't bog down your providers with so much data that it becomes wallpaper. You have to give them meaningful data, right? You have to give them something in their hand that they can look at and see that improvement is actually happening. Keep the focus of your projects patient-centric, right? Focus on patient outcomes. That kind of trips the trigger for a lot of EMS providers. They see that they're making a difference in patient outcome, and it connects with them. It resonates. Try to be transparent as you can with your quality initiatives. Explain what you're doing from beginning to end. Involve your staff with the process. Get them engaged and get them plugged into what you're working on, and you're going to see changes start to happen. But don't just spring a quality improvement initiative on somebody on a Monday morning and say, hey, we're changing everything today because we're working on a quality improvement plan. You have to explain what's happening. You have to provide rationale. Everybody wants to know why you're making changes. And if you can explain it clearly, your staff will buy into what you're working on if you've got good rationale. And it's got to be based on system improvement. Don't make it punitive. Don't ever allow your quality improvement to become a punitive thing. And I say that with one caveat. There are going to be providers who are clinically challenged. Those providers need to be identified during the quality assurance process and then remediated and dealt with through the quality assurance process. not the quality improvement process. You may identify trends, right? And be able to say, hey, I've got somebody here who needs remediation. I've got somebody here who may need some additional education, but don't make it punitive, and bring that provider in and have those conversations. And yeah, make sure that it's not a punitive process. There are lots of references for this stuff. And if you're interested in some of this, a leadership guide to quality improvement for EMS is great. And then you'll be able to dig through some of the problems that you've identified in your service. So I saw that there was an interesting chat here. Let me grab something here. Hold on a second. I saw that Claude was just talking about. Sorry, I'm getting something out of my bag because I thought this was interesting. Claude's talking about the EO Life X training device, which is this right here. So a great training device. And as somebody mentioned in the chat, I think Kyle mentioned in the chat, this device is not cleared for patient use in the US yet. However, when it is, it will be an amazing device to help provide correct tidal volume and make sure that your ventilations are effective. But yeah, it's not approved for patient care yet. It's a great training device. I make it part of my initial CPR training, and it's also part of my continued competency. So Claude, I appreciate you jumping in there and talking about the EO Life X training device. A couple of other things that I thought were interesting that I noticed in the chat. So Robin had said recovering data is great, but if it's not used in retraining or remediation, it doesn't improve performance. And that is absolutely right. You have to take your data and do something with it. You can't just measure it and then, print it out and put it in a really nice report and hand it to a bunch of stakeholders and go, here you go. Here's all the data that we collected. Look at us, we're pretty good. You actually have to build some improvement in there. And whether that's, retraining, remediation, system changes, whether we're going to start not responding to, Charlie level calls with lights and sirens, or we're going to, really tightly question why we're going to the hospital with lights and sirens. And we've got some set criteria. You need to develop some action plans for your data. Don't just measure it and then do nothing with it, which is what I see a lot of agencies do. They've got these really nice, sets of data that they print in their annual report, and they show it to the, to the stakeholders and the investors and everybody else, and the municipalities. People are really impressed with it because it looks nice. They did it in Tableau and it looks really pretty, but it doesn't mean anything unless you're using that to grow your system performance. So, we've got about 15 minutes left. If we've got questions or comments or thoughts, please put them in the chat. I'd love to be able to talk a little bit more about specifics. If you have one that is something I can maybe address or answer for you. And for those of you who are interested in the EO Life X device, this is really a fantastic tool, and I think it's interesting how folks are starting to recognize how valuable it is when you're training. Yes, Lee, I'll pull that thing out in a second. So Kyle said, any specific software that's good to start with? So yeah, I mean, it depends on what you're comfortable with. If you are an Excel guy, right? I'm an Excel nerd. I love putting my data into spreadsheets and manipulating it. Yeah, Excel's great. If you're a Google Sheets person, Google Sheets works, right? But you need to put it in some sort of manipulation tool where you can grab that data and easily sort it, because you need to be able to present it in ways that it's easily digestible. So If you want to make really pretty dashboards and graphics and that sort of thing, Tableau is my go-to for developing really pretty graphics, the stuff that stakeholders love to see, the stuff that providers can really get their heads around, because speedometers with lots of green really makes a big difference, right? People go like, wow, we're doing really well. If you are building report cards for CPR, you can build those right in your Excel, and then export those through a mail merge, and it's really easy to do. But Kyle, we can talk online or offline about some of those things. We can chat in the in Messenger or whatever. Nathan, somebody just asked about what the EO Life X looks like. Yeah, I can show you really quickly. It's a device, looks like this, that has a little sampling port here. Sorry, I'm taking it out here. A little sampling port that goes in between an endotracheal tube and a bag valve mask, or a bag valve mask, and the mask itself. Clips into the device here, measures tidal volume, measures leakage, and all that good stuff. This device, I think they're about $1,500. Super worth it. Again, all right, I'm not here to sell this device. I'm not selling this device. They didn't pay me anything, but I think it's really worth it. And yes, we can go through that. Somebody asked too, can you go back and talk about recommended points to work on for QA? Yes, I can do that. Let me just zip back a couple of slides here, and we can talk about it. There are some really simple ones, and let me just zip back here. These are, let me select my PowerPoint again. These are some of the common ones. Nathan asked about recommended points to work on for QA. These are really common ones. These are low hanging fruit. Blood glucose for TIA, stroke, and basically any altered mental status patient should have blood glucose drawn, and you can make that a quality assurance piece and then work on that for quality improvement, right? So make a quality assurance flag that any altered mental status impression, primary, secondary impression of altered mental status, stroke, whatever, gets a blood glucose, or a full stroke assessment, whatever you're using. If you're using, here we use the MFAST or the Cincinnati, whatever you use for your stroke assessment. Cardiac arrest stuff is another one of those easily data mined pieces. Compression quality, airway management, right? Effectiveness of ventilations. How long were they actually in the airway before they, when they stopped compressions and delivered capnography? I had a great case where a provider said to me, I said, how long did it take you to get the tube? And he's like, 10 seconds, man. He goes, I was in there. I saw a great view of the cords, and then I had him stop CPR for a second, and I passed the tube. And I said, so I looked at the data, and it was 84 seconds from the time that you stopped CPR to the time you captured capnography. And time is elastic. I don't think it's a bad thing to be honest about QI stuff. Time is absolutely elastic. And when you think about how long it takes, to you, it takes a split second, but when we're looking at the data, 84 seconds is an eternity. Aspirin for chest pain, super low hanging fruit. Often we see the reason that we're not getting credit for aspirin administration, documentation errors. People aren't documenting aspirin prior to arrival, or a BLS crew isn't documenting that the paramedic gave it, or the paramedic isn't documenting that the BLS crew gave it, whatever. Whatever's happening there, they're not including aspirin in the timeline. That's a big one. 12 lead from the time of patient contact. My ideal metric for that is 10 minutes. Some people like 5 minutes. Depends on what you want for your system. Again, measure what's important to you. And then if you want to look at some operational stuff, right? Dispatch to responding, the shoot time, or the amount of response time it takes, your scene times, turnaround times. Those are a little bit more difficult to change because they are kind of set times, and there's so many variables there, it's hard to measure those, but some of the others are good ones. And then of course, you've got individual metrics that are certainly worth looking at, and something that you should probably run a report on quarterly if you're not doing it, right? You should mention this. So let me go back here to a couple of, hopefully that answered some of your questions here. Let me go back and look at some of this. There are some very good guidelines that are available for building your quality improvement stuff. The quality assurance group has some good guidelines. ESO publishes an ESO guidelines packet every year that closely matches their insights. They've got some really nice, Brett Mitchell, good to see you, Brett. He mentioned that ESO has some really nice canned guidelines and reports that you can use. And if you add some filtering, you can really start to get very tightly defined reports. Josh in Washington, good to see you, Josh. He mentioned that the Zoll X Series Advanced has that real-time tidal volume metric. And I believe that is an add-on. I believe that's an additional cost. We didn't have that. It wasn't available when we were looking at our data originally. And that's an interesting thing. I've never played with that. So definitely worth looking at. And Stephen mentioned that you said that there's, graduate programs built around quality improvement. And yes, there are. And culture was one of those things that I talked about briefly, right? Changing culture is the hardest thing you're going to do with quality improvement. Though changing the texture and tempo of your agency is so difficult. We go round and round with this, and always new leaders always go, first thing I'm going to do is change the culture. I want to make this a fun place to work again. And that is boy, it's difficult. And Stephen, if I think changing culture is, if you're looking at, the 5 dysfunctions of a team, or you're looking at, some self-help books, some of those cultural change books, like, Positively Outrageous Service or things like that, you might find some tidbits to take away. There's lots of advice on cultural change, and some of it's good and some of it sucks, and you have to find the stuff that works for you. I think that getting involved in quality improvement initiatives helps you to determine how the culture needs to change at your agency. And once you start to look at trending, you can kind of sniff out where the cultural issues are, and then you might be able to address those one at a time. I found that the biggest help for me, honestly, was the class at the National Fire Academy. They offer that great class called Quality Management for EMS. And it's a 6-day course. It's free. All you pay for is food. It is such a great class because it gets you in deep in quality improvement. And they have a secondary class that goes along with that called Management of EMS. And that's really a great class that kind of addresses some of the cultural change and quality improvement stuff that goes together. Management of EMS is 10 days. Quality management is 6 days. And then they've got a class too that Brett Zingarelli mentioned, that's a 2-day class that's facilitating adaptive change. I think that's what it's called, right? Facilitating adaptive change. And that's a good one too. Taking all of this stuff together and, building some initiatives to move your system forward will be an amazing experience for you. It will be frustrating. It will be life-changing. It will be something that, you'll lie awake at night and think to yourself, how can these people be so obtuse that they don't see what I see? And often it's a communication issue. We're not telling them what we see. We're not showing them the things that we're seeing from up here because they're down here, they're on the street, and we're looking at a holistic system level view. And those guys don't see it. And if we can find better ways to communicate the outcomes and show them that the things they do make a huge difference, boy, we see dramatic change. And, you know, I would just encourage you all to go back to your agency and, you know, find one thing and look at it and identify where you can make some small incremental changes, and then measure and see if you can get anything out of this that will help you to push your system forward. And right, again, small, eat that elephant one spoonful at a time, because if you start to dig into it, you know, like wade, you know, right into that, and all of a sudden you're up to your chest, you're just going to be buried, and you will become quickly frustrated. So and right, Brett just made a point in the chat there that not everyone understands the why of a change, and that's important, right? I think we talked about that. You have to communicate those whys to your team so they understand how important the change initiative is and why it really matters, you know, when you're building those things. So, boy, this hour went quick. Thank you so much, everybody, for jumping in. Rio just posted a link in the chat on how you get your CEU. And boy, if there's anything I can do for you, I'll put my email in the chat box, or you can connect with me on LinkedIn. Just look for me on LinkedIn. Rob Walker is who I am. You'll see I'm the education specialist from the Emergency Health Services Federation, the regional EMS council here in South Central PA. And boy, I appreciate all of you guys for being part of this. I mentioned it's a little dry, but you know, I'm a passionate data nerd, and hopefully you guys are too. Thank you again. And Rio, thank you.
Rob, thank you so much for being here today. You are an incredible resource, and I'm sure everybody here feels the same way. So I will be sure to include your information in tomorrow's follow-up email as well.
Rio, would you like the slide deck to?
Yeah, you know what? That would be fantastic.
Okay.
Yep,
all right.
It goes up on the website as well, and make sure that goes on the email. Yeah, so the link to the CEU is in the chat, everybody. And if you have any questions, you can reach out to me, or you can reach out to Rob if it's regarding his presentation. And we will see everybody at the next webinar. Rob, thank you again. We really appreciate it.
Thank you, Rio. And thank you, everybody. Have a great day.
You too. Bye.